everyone, and welcome back to another insightful episode of Bits in Us podcast series. I'm your host, Hetvi Shah, and today we're tackling about a disease that is silently but rapidly reshaping India's oncology landscape, lung cancer. What's especially worrying is the rise of cases among non-smokers, particularly young adults and women. With India now witnessing a significant increase in late-stage diagnosis, the role of early surgical referral has never been more critical. Early detection and prompt surgical evaluation can dramatically shift outcomes in ways we often underestimate. And to help us decode this topic today, we have with us Dr. Shilpa Gandhi, a leading minimally invasive thoracic surgeon specializing in uniportal valves, non-intubated valves, and robotic thoracic surgery. She brings extensive global training from India, China, the UK, and Europe, and is internationally recognized for her contributions to advanced thoracic care. So, Doctor, it is an absolute pleasure to have you with me for this conversation today, and welcome to the show.
Thank you so much, MedSynapse, and thank you, Hetvi, for such a warm welcome. And yes, this is a very, very important topic to discuss, the rising lung cancer cases in India and how we can, do our best for its early detection and, which is in the best interest of the patient.
So, doctor, to begin with, lung cancer cases is rising in India, so especially among non-smokers. So, what recent epidemiological trends make early surgical referral more crucial than ever?
So actually, there is a very important trend which has been observed recently, and which facilitates or maybe it endorses early surgical or early thoracic surgical referral. It becomes more so crucial. So the epidemiology has noted a sharp rise in lung cancer cases in never smoker population from now, and more so even in women. So this is kind of an alarming, you can say an alarming sign that something now there's an unusual trend, and that should raise your horns that you should think about an early surgical referral. And there are certain emerging driving factors as well. For example, air pollution. It's rising. So this is a rising or an emerging factor contributing towards increasing lung cancer cases with an air pollution of PM level more than 2.5. Then at indoor level, exposure to your fuel consumption, the biomass fuels. And then, of course, genetic susceptibility has also been noted as a emerging contributory factor. What has been noted is that these non-smoker lung cancers, they are more prone to, the adenocarcinoma in their histopathology. And well, that's a good sign, because these, if detected early, these are they're operable in early stages, and hence more so you should be, raising all your horns to, send these patients to your thoracic surgeons early. One more important factor I would like to stress is the diagnosis of these cancers at a much younger, younger age group. So the age group of 40 to 55 is called as a younger age group, and then rising cases of lung cancer in this age group is also alarming as compared to the Western cohort, where the cancers they develop, in a much elder or in the older people. It's good because younger population actually they will tolerate the surgery well. They have better outcomes, provided we give them a timely surgical referral. Like I said, there's air pollution, environmental kind of exposure and all. So they are also prone to develop adenocarcinoma, which is again, peripherally located in the lung. Otherwise, previously we used to have more central lung cancers, which always were, most of the times they were inoperable or difficult to operate and amenable for chemotherapy. But now there is a shift noted from central lung tumors to peripheral lung tumors because of the rising or the emerging factors. So the newer factors, if they are peripherally located, again it's good, because if you are going to detect them early, you can provide them, full R0 surgical resection, and that too by minimally invasive approach. Our diagnostic diagnostic abilities or diagnostic imaging levels are also improving. We are more or less like widespread. We are using widespread CT for even small nodules in the lung or every suspicious nodules. That's a good sign, because I think you will detect early. You detect all these suspicious nodules much earlier, and if they turn out to be cancers, they are definitely curable by surgery alone. I think these are some of the factors which you really need to take into account for early thoracic surgical referral. These are all the trends which are being noted now.
I think that's a very important perspective also, especially the shift that you mentioned and the age group that you mentioned is really important, and actually it highlights how fast the landscape is also shifting for lung cancer. So now, doctor, from a clinician's point of view, what are the key clinical signs, imaging findings, or diagnostic triggers that should prompt an early referral to a thoracic surgeon?
So there are definite clinical telltale signs, or I can say red flags. So if somebody around you is having a persistent cough, for example, for more than 3 weeks, and it's still persistent despite all the medical management, especially in a non-smoker, this is really an alarming sign or alarming symptom. Then, of course, there are standard unexplained weight loss, unexplained fatigue, and reduced appetite. There is a history of recurrent pneumonias, recurrent hospitalization, particularly with the pneumonia in the same lobe, happening again and again. Then there must be, something obstructing lesion inside the, one of the airways, and that should be a suspicion for a lung cancer. And hemoptysis, even if it is a small streak of hemoptysis, if you see it in a female or another smoker person, then it should definitely, or in a younger age group, again, it should alarm you, and, you must investigate or think about your thoracic surgeon at a much earlier level. If I have to talk about the imaging or again, the imaging factors, or there are certain imaging signs you see on your CT scan, which are again a telltale sign. They're standard telltale signs that, this is you're dealing with a lung cancer rather than just a simple nodule. So if there is a solitary pulmonary nodule, for example, SPN, but of more than 8 millimeters, it's constantly there, or it's increasing slowly or gradually progressing in the size, then of course it is you're dealing with something suspicious. If it's a part solid or a ground glass opacity, and it is persistent for more than 3 months, then of course you're dealing with something sinister, because they turn out to be, adenocarcinosis in most of the occasions. Then if there is a spiculated mass on a CT scan, or if there is a lobulated nodule on a CT scan, these are typical features of you're dealing with a malignancy. If there is a new pleural base lesion you have noticed, and there is no underlying infection, so the patient is clean otherwise, and of course it is again a sinister finding. Then if there is an endobronchial lesion, again an upfront indication that probably you're dealing with something doubtful in your lungs. And if you've done a PET scan and the nodule is showing a heavy uptake, heavy SUV uptake, and that to a resectable pattern, I think it should really lock all your horns that probably you are dealing with a lung cancer, or probably it's a cancer. And then nodes, again, even if they are small, but then again, if they're showing a high activity on a PET scan, showing a high SUV uptake, then even if they are N2 stage, it should alarm you that you are dealing with a lung cancer.
I think that's very useful, especially for physicians who are often the first point of contact for the patients. So it's really important to look out for those red flags. So now, doctor, I feel that despite awareness, delayed referral is still a major challenge, especially in India. So in your experience, what systematic or clinician level barriers contribute the most to late surgical evaluation?
So yes, unfortunately, despite having so much information with us, we are still dealing with delayed referrals and how we can target. So we will have to assess what are the barriers, and the barriers are really at the various levels. If I have to talk about, so we start with the healthcare system as such. So the barrier of the healthcare system would be there are there is we can say there is a shortage of dedicated thoracic surgeon, especially in a tier 2, tier 3 city. So there is a piece of the patient then needs to, travel to a city or a mid-level city or a metro to get the facility of a thoracic surgeon, which is again a burden to the patient in many ways. Fragmented care, I would say. The patient literally lingers between a GP and a pulmonologist and an oncologist, and this loop is like a vicious loop, never-ending loop, even before meeting a thoracic surgeon. So unfortunately, the surgeon is sitting in a higher ladder, and the patient misses this early referral in that way. Patient is trying to get a CT or a PET done in a tertiary center or an institute or a government center, because of the, probably the cost is the reason. So of course there's a lot of waiting time. He misses, he loses out with a critical time period, the early time period for early investigation. And I think and multidisciplinary tumor board. So that in some places they are there, but the lack of adherence to it, and in many other places they are not there at all. So I would say lack of multi-NDT tumor boards or adherence to these NDTs is one of the outside the metros, especially outside the metros. So this is a very important factor at the healthcare level. At the clinical level, there is, I would say, there is a myth that surgery should be given only to very early stage of lung cancer. No, that is not the way it works actually, because the patient needs to be assessed as a whole. So the surgeon should be involved at a much earlier stage, I would say even before the biopsy. Then again, there's another myth that there is an overestimation of the patient risk. For example, the patient is having a COPD, or he's having a low ejection fraction, borderline lung function tests. So the surgery is not amenable. No, that is not true. Again, we can definitely use a VATS or a robotics or minimally invasive techniques we can use in these kind of cases. So we can make these patients fit for surgery, but again, you have to involve a thoracic surgeon at a much earlier level. And I think so many of the clinicians, they are over investigating the patients and losing out with a early golden period of referring the patient to the surgeon. So over investigating, losing out time. I would say the thoracic surgeon prefers to see the patient much earlier. They prefer getting involved with the patient much earlier, even before the biopsy. And then I would say there's a fear that we have not done the biopsy of the patient. We don't know what it is. It might be some, it might be normal. So let me get the biopsy done of the patient, and then we will think about the surgeon. No, that is not the case. I would say that we have already by now we have listed a lot of telltale signs and symptoms, and if any of these are present, the suspicion itself is enough to establish a thoracic surgical opinion or a referral. And patients, yes, of course, there are certain standard factors associated with patient level barriers, for example, financial concerns and the need to travel from a rural area to a metro city, or maybe to a tier 2 city, or wherever the surgeon is located. If she or she is located 600 kilometers away, then they will have to travel. So there's a logistic burden. And then, of course, in much rural areas, patients tend to divert themselves to attain local healers or alternative therapies, or the quack therapies that we can say. And that is something it's very difficult to tackle, but that is a problem. We need to really see how we can solve that.
Yeah, and I think it should be solved at all the levels rather than just one level is something even I feel. Yeah. So now coming to surgical advancements in this field, so VATS and robotic thoracic surgery have transformed patient outcomes. So how have these innovations improved surgical safety, and how do they support earlier decision making for reduction?
Yeah, so I think, yes, this is a trend of, the less is more. So minimally invasive. So that is what the trend is. And you don't have to miss the boat as well. So because they really are offering a lot of advantages. For example, So there is an improved safety, of course, when you're doing your surgery by a VATS, a video-assisted thoracoscopy, or by robotics. So there is improved safety. There is reduced blood loss, early discharge, early resumption of your activity, less hospital stay, and hence less pain, early ambulation, and hence lesser financial burdens, I would say. To summarize, there are multiple advantages of VATS and robotics, but out of this, one advantage really stands tall, and that is they have expanded the pool of operable patients. For example, again, I've mentioned in the past that you can offer VATS or resection of your lung cancer if the patient is having underlying COPD or a low ejection fraction. Or if it's an elderly patient, or if when the high frailty score, because these can be done. So you can do a safe or a curative resection by VATS itself. So and since it's less morbid, there will be early recovery of the patient. And of course, we all know by now that early stage lesions, they are best treated by, minimally invasive thoracic surgeries or minimally invasive techniques. So they are the best cases actually to prompt an early surgical referral. And of course, like I've already mentioned, that you will achieve a precision or oncologic completeness, R0, full, R0 resection even with VATS and also. And nowadays, I think patient acceptance is improving when they see or when they hear the word, the keyhole surgery or, minimally invasive surgery. So I think they have a less anxiety and less fear. So I think, yes, they are also themselves getting encouraged to adopt these kind of techniques or these kind of approaches.
So from a healthcare perspective, how do you feel that the minimally invasive surgery has actually transformed in for healthcare practitioners majorly?
So I think the points would almost remain the same. They have really, it's a revolution. Literally, they have changed, and more so in cancer surgery, it's literally a revolution, because these patients, they are already anxious because of the underlying cancer. And if they are detected early, you can subject them to a minimally invasive approaches. And there are innumerable patient experiences, patient reported outcomes, and literature and the data which have now proven long ago or decade ago that these techniques, they are safe. They provide curative intent. They are associated with curative intent, and they provide an R0 or a complete oncologic clearance, which is important. And even in borderline patients, they are safe. So actually they are the approach of choice even in borderline patients. So yes, they have dramatically improved the surgical landscape of the thoracic surgery or the surgery as such.
Yeah, that's brilliant actually. So now, doctor, many Indian patients present with comorbidities like COPD or limited lung reserve. So what prehabilitation tools or objective assessments help determine a surgical fitness early rather than ruling out surgery prematurely?
Yeah, so I think, yes, COPD, it happens because of, chronic smoking and some of the underlying autoimmune conditions. So for few of the risk factors are actually modifiable risk factors. So you need to have a standard and a stringent rehabilitation and assessment program for COPD. For example, you need to have a 360-degree pulmonary evaluation. The patient should be subjected to a full pulmonary lung function test, including spirometry and a TLCO, DLCO. Why? Because these two factors, especially the FEV1 and the DLCO, they are strong predictors of a post-operative outcome which you are going to achieve after the surgery. Then, if and when required, the patient you should have the facility of cardiopulmonary exercise testing or a CPET in certain selected group of patients, or because these patients might need the CPET estimation as well. And I would say the most important would be a quantitative CT, where you can actually assess the emphysema distribution, the target areas, the target zones, the CT fissures, and the functional lung segments. And then you can actually decide how much to remove and how will the patient behave after the surgery is done. About the prehabilitation, it is again standard but very important. The strategies are multiple. For example, so you start with number one, smoking cessation. Smoking cessation is mandatory prior to surgery, at least 4 to 6 weeks prior to surgery. Then early ambulation, good spirometry prior to the surgery. So if you fix the date after 3 weeks, a good 2 to 3 weeks of extensive pulmonary rehab or a prehab, deep breathing exercises, inspiratory muscle training, and nutrition optimization, for example, protein supplementation if the patient needs that. So this prehabilitation is important. Then if you're assessing the frailty of the patient, again, by doing a staircase test, you are assessing the fitness or the performance score of the patient, or by the 6-minute walk test. These are simple tests which we can do literally, in an OPD level, at an OPD level. So I think they are very easy to do. And the most important is many of these patients, I prefer to actually subject them to a perfusion scan as well to see, especially in a borderline lung capacity group, to see how much lung will be remaining and how much, physiologically normal, I would say, lung function you would be having once the lobectomy or segmentectomy is performed. If I have to summarize, many of these COPDs otherwise are wrongly labeled as unfit or a borderline or inoperable, not unfit, inoperable, but they are if you're adopting these strategies, they can be made fit for surgery. So one must know where to hit, where to hit and how to hit all your target problems so that you can achieve a better outcome.
So I believe that's like a balanced approach should be is more preferred rather than just sticking to one approach. So now, doctor, finally, for clinicians practicing outside tertiary centers, practical referral pathway coordination model can ensure that potentially operable lung cancer patients reach the thoracic surgeon without any delay.
Yeah, so I think there is a need of establishing a practical and easy referral pathway, something which is replicable even at a GP level or a rural level. So how you can do it? Number one is just spreading the awareness that for early recognition or an early detection. But we've already seen, symptoms, and CT. So all of this, they are telltale points that you're dealing with something suspicious. As soon as you're suspicious about the lung mass, it should be subjected to an early thoracic surgical referral, or at least a communication should be established with your thoracic surgeon. Then once you're seeing these patients in your OPD, you should subject it to a parallel test. So you auto test parallel rather than waiting for, okay, I will do the CT first and let me get the report, and then if something sinister is it, then I'll start the biopsy and then I'll wait for the IHC. So IHC comes in 4 weeks. So the patient has lost precious 4 weeks, which is an early, it's a very, very big period for at least a cancer patient. So you must order all the tests parallelly, but do not strictly wait for it to complete. If you're sure that you're dealing with something sinister or something suspicious on various on the above factors, like I've already mentioned them repeatedly. So because surgeons, I'll repeat again, surgeons, they really prefer to get involved much earlier. Thoracic surgeons, they prefer to get involved much earlier, even when the biopsy is not done, and if you're thorough that you're dealing with a sinister nodule or a sinister mass. And there is a major role of virtual consultation or virtual review. So at this point, if you're dealing with something suspicious, lung mass, you can establish a WhatsApp-based communication or sharing a simple sharing of these reports or images to your thoracic surgeon actually is enough to establish an early thoracic surgical opinion. Once this is done, you can actually fast track it. You can fast track this, so your surgeon will then should be able to give an early appointment, maybe within 2 days of referring. And so the whole goal would be, if you're sitting in your OPD and seeing this kind of a patient, and there is a doubt that this can turn out to be a lung cancer, your surgeon should be able to see this patient and give a thoracic surgical opinion within 7 days or within 7 to 10 days of the first suspicion. Only then, this is the end goal. This is the fast tracking or fast track referral, we can say. So yeah, I think this is it. One more important, there has to be a clear communication that that the patient is undergone a CT at your center, and so you must provide the full information of what was the size of the nodule, what were its characteristics, how big it was, what was the region, were there any other nodules. So if it is incomplete, a patient is going to go to the thoracic surgeon, but he's going to get it investigated again. So this will be another waste of time, finances, logistics, and a lot of wastage of time and a lack of faith as well. So all of these things are all small, but they're all minute details, but very important, and one must adhere to it.
And I think that's extremely actionable advice, and I think many clinicians will also help streamline referrals more confidently and more as you also mentioned, communication is the key. So it's really important. So Doctor, before we wrap up, do you have any final thought regarding lung cancer and thoracic surgery, especially in Indian context?
Yeah, so I think important thought can't really summarize in one sentence. So there are certain additional factors which are really pertinent for the Indian region. I can just give some valiant, certain valid points or salient features I can give at various levels. For example, patients, they still have a myth. There is a patient level perception. They still have a myth that, if they're coughing for long term, so it might be a smoker's cough, or this cough is associated with pollution related, So I think that is, one must not wrongly label your symptom. And if it is surpassing a specified time period, one must see your pulmonologist and then your thoracic surgeon. There is one consultation is not going to harm rather than delaying that one consultation. Still, unfortunately, stigma is there that it is a cancer, so it is going to spread. If you get it biopsied or if you get the surgery, there's a chance that it might spread. So especially in the rural areas, there is still stigma associated with the cancer. And most important, in India, still many clinicians, they treat lung shadows with along the lines of tuberculosis. And once you see something sinister on a chest X-ray or a CT scan, they are subjected to empirical TB drugs. And once they start TB drugs, they lose your 3 to 4 months, and by that time the early stage or the early cancer actually advances and becomes unresectable. And like I've also mentioned, the patients, they are heavily still relying on local healers or alternative medicines or quack therapy. So I think there are a lot of factors. So there's a patient level factors, then investigation or diagnostic level factors would be the clinicians themselves. They are over enthusiastically investigating. And then, after the completion of the investigation, they think of sending the patient to the surgeon. By that time, the patient is already exhausted financially and, physically and logistically as well. Many of the ambiguous findings, they're wrongly labeled. For example, a GGO is treated as an infection, or the SPN. Even if it is small, so it is continuously put on a 3 monthly follow-up pathway. And many of these kind of patients, they actually don't adhere to this follow-up pathway, so they miss out of that channel as well. Then the most important, literally the most important in the Indian scenario, and there is a poor coordination between the doctors or between the specialties themselves. So the patient sees a pulmonologist, and then he goes to the oncologist, and then he goes to the general surgeon, and again goes back to a pulmonologist, and again goes back to an oncologist, and finally somewhere at the end he manages to see a thoracic surgeon. By that time, he literally loses out his critical time period. He gets exhausted. this is a vicious loop, and it needs to be broken or discontinued or disconnected at some point. And if you're able to bring a telemedicine or a technology revolution, that will be really helpful to the patient, to the patient population. So if you're able to establish a telemedicine consultation or a teleconsultations or MDT or a digital records, appropriate digital records, patient records, then that is important. You're preserving the data, and you're not needing to repeat it again and again when the patient goes to your surgeon, which is outstationed or probably away from your center. That is important. I would want to mention one line on even the economics of the patient. So in tier 2, tier 3 cities, there is a lack of insurance coverage or small insurance packages. Unfortunately, they are not enough to treat to surgically treat your or to perform a lung cancer surgery. These are not very cheap surgeries, or they're not cost effective to get a full safe and curative outcome, especially for the robotics and the VATs. So the lack of insurance coverage is something which we need to really talk about. And there is knowledge gaps in between the physicians also. So like I said, every lung shadow cannot be treated as tuberculosis. So there is a genuine lack of knowledge or a knowledge gap in between the physicians. Physicians, when they are seeing these kind of patients in their OPD, they must or they should counsel the patients appropriately about early surgical referral, curative intent, and the benefits of the minimally invasive techniques. So poor counseling is a factor which is going to discourage the patient to actually see their thoracic surgeon. And of course, there is always a professional hierarchy which is always going to be there in wherever you're practicing. So that needs to be sorted out. There's a professional hierarchy between the senior doctor, junior doctor, or pulmonologist, or thoracic surgeon. So where this show and policies, we don't have standardized policies. So we have for example, in India, we have like a breast cancer policy. So when you have to do a breast cancer surgery, many of the people now, they know, many of the institutes, even smaller ones, they know. Or there's an existing cardiac care policy. But for lung cancer, there is no standardized policy or a standardized referral pathway or fast tracking, how we can fast track, how we can define the timelines, when to operate, when to see a surgeon. And most important, there is absence of screening program. There is a definite absence of lung cancer screening program in India. And even if there is an effort of initiating it, there is no effort to adhere to it. So this is very important factor, especially as compared to the Western cohort. India faces a lot of barriers to establish a timeline or a timely surgical intervention.
I think these are some very realistic points that you mentioned. So thank you for sure. And I feel down the 5 years lane, I feel some changes is very much necessary. And I think there would be many changes also. So let's just hope for the best. And Doctor, as we wrap up this session, thank you so much for these valuable insights, and your clarity on early referral, surgical advancement, and practical pathways will surely help clinicians optimize lung cancer management at the right time. So thank you, Doctor.
Good. Thank you so much for this opportunity, and I hope I have contributed my 2 cents of information and knowledge. I've always very important problem, and thank you for this opportunity.
And we look forward for more also. And to our audiences, thank you for joining us for this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the Medicine Apps platform. Medicine Apps platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, take care and stay ahead in the field of medicine.